Dear viewers, welcome you all to our show, Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks, keeping distance, and definitely by getting vaccinated. Dear viewers, today our topic is management of non-union of long bones by the magical Ilizarov. And our honorable speaker is Professor Novikov sir from Russian Institute of Ilizarov, Kurgan. So welcome to our
Good
show,
afternoon.
Orthopedic
Good
Solution
afternoon,
Academy.
colleagues. Good
Good
afternoon.
afternoon, sir. Dear viewers, we have an academic panel with us, the legendary professor of Bangladesh, Professor Mofakkarul Barrister. I would like to welcome Professor Mofakkarul Barrister to join with us.
Thank you very much again, Tanvi. Thank
Thank
you.
you, sir. Thank you for joining with us. Dear viewers, we always face challenges in case of non-union, but the ultimate solution is Elizarov. And we will show you how we can manage the non-union by this magical Elizarov. And our honorable professor, Professor Ravikam sir, will show you how we can overcome these challenges. I'm Dr. Mohammad Tanvir Ashraf is with you as a moderator. Now, I would like to request our honorable speaker, Professor Ravikam sir, to start his presentation. Professor Ravikam sir, please.
Thank you for your invitation and possibilities.
Dear viewers, we have to wait for a minute just because of, I think, our Professor Ravikam sir is disconnected uh, for a few minutes and he will join within a short time of period. Because of Professor Novikov sir is not with us, I would like to request Professor Vapakrul Baris sir to say something about the uh, uh, starting of Elizarov in case of treatment of non-union. Because of we don't want to waste our valuable time, as we
Yes.
have legendary Professor Vapakrul Baris sir with us. So we can see you, sir. Professor Novikov sir is with us now. Sir, would you please share your screen with us, Professor Novikov sir?
I try my best, but I cannot.
We can see you and we can hear you, but no slide.
And just now, did you see slide?
No slide.
Uh, no slide, sir.
No slide.
I don't know what's happened.
Where
Very
is Andrei?
sorry. Слушай, у меня...
Где Андрей? А почему сегодня так случилось? What happened today? Ой, 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 ой. Okay. Now, regarding the non-union of long bones, it's very crucial and important issue in orthopedic surgery. Very important and crucial. Non-union means sometimes you can see the day one, as for example, fractured neck of femur. The alignment is not good. Alignment is not good. If you treat the patient with nail or DHS or something, or by wires, and if you see you have a malunion, then it will go lead to non-union. This is number one. Number two, whenever you see very big long bones, after the road traffic accident or road traffic trauma, the 15-20 centimeter bone is out from the thigh or tibia, then it will go lead into non-union. And if you think about the definition of the non-union of the long bones particularly, I have my own classification and definition. Arrest of bony fracture repair process with the formation of fibrous or cartilaginous tissue in between the main fragments, and fracture has remained ununited for 6 to 9 months. 6 to 9 months, and which is based on X-ray and clinical findings. Then you can say this is the non-union. Sometimes you can see any bone which is very big gap, which is malunited, not united even. It is going to be malunited, then it may create a non-union. So in orthopedic surgery, non-union sometimes you will get with infection and without infection. Even then, if you go for interlocking nail or plating, you may get non-union. And sometimes, if this non-union persists for a long time, you will get a discharging sinus all the time, and this discharging sinus will disturb you to make the union. So, if once you have put the interlocking nail or plates, and if you see the bone is going to be non-union, then you should have to remove all these things, and bone is going to shorten, and you can debride that part, and then you can go for application of Ilizarov, and at the same time by doing the corticotomy, unifocal or bifocal, depending on your shortening of the bones. So these are the main things. Any kinds of deformity with non-union, you can also treat by Ilizarov, deformity, non-union, shortening. 3 things. And at the same time, sometimes you'll get the osteoporosis. Bone quality is not good. You can treat osteoporosis, you can treat non-union, you can correct the deformity, and you can go for lengthening by Ilizarov. Ilizarov, the beauty is thick. This is a 3-dimensional mechanism, technique, 3-dimensional. From that side, multi-level, multiplanar deformity correction, you can do that. So this is the beauty of Ilizarov in case of non-union of the long bones.
Sir, in case of infected non-union, what will be the procedure of management by Ilizarov?
If you see the infection, discharging sinus is long and there is a dead bone or sequestrum, especially for the adult, it's better to remove that one. During the Ilizarov era, he treated even this infected non-union without doing any debridement by stabilizing the fragments with the Ilizarov, but it takes long time. But for the children, you believe it or not, you don't need to do any kind of debridement in children. Only the biocompatible thin wires, you fix that one with Ilizarov fixator, and you can get a very good outcome, good result in case of non-unions and osteomyelitis also. Novikov, already you are here.
Вы меня видите?
Yes, I can hear you.
I don't know what's happened.
It's okay, sir. No problem. Sometimes it happens, sir. We can hear you loudly and we can see you clearly. So,
if you don't want to show your slides, you talk now. Without slide, you
no
talk.
No problem, sir. We will discuss about the matter.
Just very sorry, colleagues, but I think This is problem each doctor meet with pseudoarthrosis. With doctor meet situation when we haven't excellent good regeneration. And just now I wait computer manager, he will help me. And if we will start not from situation with pseudoarthrosis, I won't talk about situation before pseudoarthrosis, because many time we check X-ray without knowledge about, without recommendation from radiologist. And if during the treatment, if usually pseudoarthrosis we have after osteosynthesis with plate or with nail, if doctor talk with radiologist, I think more than 50% patients will go away from pseudoarthrosis. And during the treatment with lengthening, during the treatment with correction of deformity, same situation. Sometimes doctor interpretate picture of X-rays with his experience, without asking what you think, what your opinions about this time of treatment. I again talk about radiologist. For example, in our department, during year, maybe one patient has pseudoarthrosis with apparatus Ilizarov. Why? Because each X-ray before me check radiologist, and then he inform me condition and situation with regenerate. And for example, sometimes I have planned lengthening for 8 centimeters, but radiologist stopped me because his eyes more better than mine, and he feel bad situation before when bad situation will come. And I recommend collaborate with radiologist. And just again, I try show screen. And in our department, we have, in our institute, we have special department where treated patient only with pseudoarthrosis and defect. And all of technique, all of variant of treatment before patients, Ilizarov, from Ilizarov time and till now, doctor first did on the animals, on the dogs, on the rabbit, or another animals, and only after that some techniques we start use in our operation theater. I want, maybe just now I try again, start. Did you see me?
Yes,
Presentation.
sir, we can see you clearly.
But presentation start or no?
No.
No.
Very sorry. I try my best, but something wrong.
Okay, sir, no problem. We can discuss it verbally about the non-union if the slide is not open.
Without slide, you talk.
Yeah,
No, because
yeah. And
you talk without slide.
bad situation because just now pseudoarthrosis very young. Many young patient has pseudoarthrosis or defect. I don't know why. Maybe this is food, maybe condition of government health. I don't know. But 20, 30 years ago, we haven't so many young patients with pseudoarthrosis. Now, very not bad, but difficult situation with pseudoarthrosis here. And we have a special department, infection department. There are so many patients with defect and pseudoarthrosis. And Dr. Bari, usually your patients, infection patient and clear patient, treat in different place or in one department?
In my center, I treat with infection, without infection, but the rooms are different. OT, I have infected OT individual, but I have clear OT also individual. But we are treating the same hospital, not like Kurgan.
And very interesting, few years ago, we have not many, but we have amount of patients. I work in clear department. And if we have some infections, including of pseudoarthrosis, we shift this patient to the special department, infection department. And now, very strange, sometimes with big defect, not bone, soft tissue. In our department, we have a special surgeon. He help us with soft tissue. And from infection department, we shift this patient in our department. Why? With only one reason. We start clean with water, with soap. We evacuate microbes. And all of infections with water go away. Very interesting, fantastic. Without any antibiotics, only clean. I try again because Friday for our institute, little bit busy. Big meeting, not like examination, but all of departments present results during this week. Administration's meeting. And Andrei, this is our excellent man, just now help in other place. Little bit later, he will help me. Because now our institute start very intensive prepare all of departments for celebrations of Ilizarov. А что-то случилось? Они в ординаторской? Если нету, то я на пост положу.
Is there any protocol to manage the infected non-union in Russia? Do you have any protocol?
This is depend of case. Tibia, femur. This is depend of segment, depend of atrophic, normatrophic, or hypertrophic, depend of shortening, and protocol for all of situations we haven't, because all patients is unique, and for any patients we start select unique best way. I try again.
Sir, we are doing lots of interlocking intramedullary nailing in case of tibia, and we are facing lots of infections in those cases. What should be the management protocol in case of these type of cases that we have done interlocking nail in case of tibia followed by infection there? Then what can we do by Ilizarov?
First, we need to remove resin. And if we have any metal on the bone or inside intramedullary nail or plate, first must remove, then clean, then remove some bone, then put Ilizarov frame. And many years ago, our protocol was first remove bad metal, take rest, then come again, and we start treat with Ilizarov methods. Just now, the patients haven't time, and many times we help simultaneous. We remove bad metal, we clean, we remove bone, and same operation we put on Ilizarov frame. Patients no want lost time, and we have not so bad result, not excellent, but we save time.
Что, заработало, нет?
Нет.
Давай. Время быстренько. Я через 5 минут включения уже устроил там все. Приветствую. Так. Так, есть.
Вот скрин. Так, я и нажимал. Выберите экран. Вот так. Вот выберите экран. На весь экран. Так и нажимал. Все нажимал.
Так.
ওই
Нажимал.
তানভীর এই যে কাজ করে ওটা বলে ওর নাম পুরা ইনস্টিটিউটের ফটোগ্রাফার।
Так.
সে সব ছবি টবি কোথায় গিয়ে অনেক বছর ধরে আমরা তার সাথে ইয়ে করি। ভেরি জেন্টলম্যান, নাইস ম্যান, কম্পিউটার মাস্টার, ফটোগ্রাফার আরো দুজন আছে, তিনজন। ওরা হোল ইনস্টিটিউট ঘুরে যখন কোনো কেস কোনো এটা সেটা ওদের সিস্টেমই আলাদা। আচ্ছা, রিগার্ডিং দি নন ইউনিয়ন, সে যেটা বললো নেল রিমুভ করো, আগে ওয়েট করতে বহু আগে। আমি তো কোনোদিন ওয়েট করি না, আই নেভার ওয়েট। You remove the nail. Yesterday I did one case that was sent by one orthopedic surgeon from Chandpur. Comminuted fracture, lower 1/3 of the tibia. Comminuted fracture, lower 1/3 of the tibia, and he put the interlocking nail, orthopedic surgeon, and then what happened? Non-union and breaking of the screws, everything, infection. Then I remove everything. Right to the huh?
Должен видеть. Вот он.
Да, видно. Видно.
Presentation.
Yes, it's okay.
Yes,
It's
I can
okay,
see
sir, now.
You start.
It is okay. You can start now, sir.
Yeah.
Говорите, погодите. Okay.
We can start?
Yes.
Yes, sir.
Закроешь?
Quick. Novikov, quick. Быстро.
Да, хорошо. Thank you very much for your time. And colleagues, continue to celebrate this year, 100 years since Ilizarov birth and 50 years of Kurgan Ilizarov Center, and some planet in the sky. And treatment of patients with arthrosis and bone defect by Ilizarov transosseous osteosynthesis, very important topic in our job. Common in technology vascularized autograft straighten vascular connections with the soft tissue of the segment are adequately supplied with blood, resistance to infections, and are capable to complete organ-topic reorganizing. I want to show some technique replacement of a post-resection defect of the radius formation after resection of osteoblastoclastoma with free autograft of the fibula with arteriovenosis shortening. Not so many, but each month we have patients like that. And disadvantages this technique: traumatic, minimum 2 stages, technically complex, the operation is long, very long, implies those of microsurgical equipment and mandatory expensive. and we need medical support. And advantages of free bone grafting with the vascularized autograft. This is short-term osteosynthesis, no need for long-term inpatient treatment. And this is clear gold picture because non-free bone grafting by Ilizarov. All of the world, many countries use this technique. And when we have a true bone defect, this is any loss of bone matter, the total value of the diastasis of anatomical shortening of segments, and more better will explain about bone defect, excellent magic doctor from your country, Professor Barry. I only touch this topic. The volume of magnitude after estimated bone losses take into account in the planned removal of non-viable grafts, resection of the ends of the fragments and their necessary duplications as the joint. Classifications of defect, very old classifications, defect pseudoarthrosis and defect diastasis. In the conditions of transosseous osteosynthesis, the adaptations of the ends of fragments closed and open compressions of fragment, and the main tense of compressions between fragments depend of complex of factors. All of this picture from experimental material, from dogs. When we have radiographs and histotopogram with closed adaptation and open adaptation. Generally, we on this picture need see what is it blood supply. Without blood supply, impossible get excellent regeneration, impossible get callus. Shape of the end of the fragments, transverse, situable, form compression along the axis, beveled, suitable, four corner lateral compression, and number 3, composite, a combination of compression of this axis and on the opposite side. Very easy scheme and very effective, creating longitudinal compressions along the axis of the fragments. And all of these patients with pseudoarthrosis, we have from another osteosynthesis. Because just now from Instagram, so many patients and another doctor ask why you use Ilizarov frame when we can use plate and patients from second day can go home without any external fixator. And just now with this picture, very easy answer why we still use and we will continue to use external fixator, magic frame, when we can manage on during the all of our treatment. And during the treatment, patient can everything. And if situation need, we can correct with any way. And I want back again. You see picture before and picture now. Only magic compression. Only situation when we can give freedom and when we improve blood supply. Everything from forces from inside of body. This technique of closed splice of fragments with the creation of contralateral compression using the beam. For pseudoarthrosis, we very often use beam because forces more than a simple rod. Very good example. After intermedullary nail, we have pseudoarthrosis, then remove and simultaneous we start support this patient with Ilizarov fixator. Immediately patient can start walk, and during few months we can remove with excellent consolidation. And during the treatment, patient walk without any support and take all of weight bearing with good function of knee and ankle joint. For us, this is difficult because humerus, because very difficult take proximal part of humerus, and how we can do contralateral compression with wire with a lever. This is possible. And we can see result в пути. This is old but effective classifications for understanding of situation. Оль, я перезвоню, хорошо? Atrophic, normal trophic, and hypertrophic. If we have atrophic, we need open adaptation of the ends of the fragments. If we have normal regeneration of pseudoarthrosis, osteogenesis in the area of pseudoarthrosis. If we have hypertrophic, this is closed adaptations of the end of fragments with meteorite stretching of the tissues in the pseudoarthrosis zone. The purpose of the fragments and rehabilitation process is to restore and anatomical function, integrity of the limb. This is bone defect compression, restorations of the integrity of the bone skeleton of the segment, restoring the segment length, elimination from segment deformities, elimination of visual contractures of adjacent joint. Ilizarov system of reconstructive, the restorative methods of patients with defect of false joint of joints bone, close material stretching of interstitial tissue with the formation of regenerase, intertibial synostosis, elongation of fragment and fusion as the function. Close material stretching of interstitial tissues with the formations of regenerations, intertibial, synostosis, elongations of fragments, fusion of the function. And all of this technique, Ilizarov with his colleagues, Martel Dichkova, Professor Barry, very good know this, Dr. Cameron, publish in our magazine, we publish recommendation for treatment to the health ministry. And from Ilizarov time, we still use monofocal distraction compression variant of treatment. Very effective and very common. Still, any technique we need show for our ministry, we already print. This is already legal. So many articles we have on this topic. Bifocal compression destruction osteosynthesis. When we have shortening and when we have situation when we need bone transport. And next presentation, Dr. Barry will explain. And all of this technique come from this picture. Many years ago, we did this surgery on the animals. Да. Ой, извините, пожалуйста, я сейчас на вебинаре. And Dr. Barzunov has big experience, and this is material I took from him, and he too with me and with Dr. Klushin and Professor Shevtsov was a guest on your conference, and Dr. Barry invited us, and we have excellent magic time in Dhaka. This is scheme of osteosynthesis in the replacement tibial defects by multi-level elongations of the proximal tibial fragment. And for understanding from where coming regenerate, with red color we show from very small blood vessels. And first, when we put metal, we need think about soft. We need think about blood vessels, and we need give all our attention and all our respect for grow blood vessels. This is a time I can say same like pregnancy when we weigh baby. Same. This is a picture from experiment from animals, and you can see different situation with blood supply when we have good or bad blood supply. All of this experimental study. Polylocal destruction, compression, osteosynthesis, and multi-level elongations. And here you can see what's happened inside of our bone. Without this net, we haven't any callus. Magic for understanding. Very strange, but when you will anytime imagine what is it newborn start from blood. Without blood will only hole, only distance without any result. Again, this is came from Ilizarov time. Scheme of osteosynthesis in the replacement of tibial defects by multi-level elongation of the distal tibial fragment. And again, without grow vessels, arteries, we haven't chance for consolidation. Poor dogs give us knowledge and give us possibilities to help our patients. Scheme of osteosynthesis in the replacement of the tibial defect by elongations of both fragments of the tibia, proximal and distal. Again, experimental study. My father, Professor Shevtsov, has a very big experience with pseudoarthrosis and defects. Methods of intertibial synostosis. Again, all of this knowledge we take from experimental study. All technologies for filling bone defects and false joints have been experimentally tested and are currently being widely implemented in clinical practice. And Ilizarov methods allow the doctor to correct the error with any osteosynthesis and prevent complications, because pseudoarthrosis and defect, this is severe complications with another technique. All my presentation, I show this is few words from heart of our colleagues from Iran. Ilizarov feel any defect in life-wave bone. When you are helpless in orthopedic treatment, think to Ilizarov. Extending the quality of life by Ilizarov lengthening. When all links are off, the light of Ilizarov is on. Surprising, unbelievable even by Ilizarov. The end of disability by Ilizarov. Bright future and disability by Ilizarov. And this is high from Tehran. And again, our teacher, our father, our grandfather, our spirit, and our future. Ilizarov give us possibilities, give us freedom, give us, for me, everything. I want to congratulate, I want to say thank you very much for your time, and I want invite you for collaboration. And if you have any questions, you can write me directly in Instagram. Thank you very much.
Thank you, sir. Thank you for your nice and brilliant presentation. And that was a highly informative presentation. Sir, I would like to ask you one. No, it's okay, sir. It's okay. I would like to ask you one question regarding the atrophic non-union and hypertrophic non-union. In case of atrophic non-union, do you refreshing the bone end before putting the Ilizarov?
Yeah, we refresh. If we have atrophic, must open reduction, refresh end of bone, must. And sometimes now, if this is baby, we not to do distraction and compression. We use only compression. We did little bit short, and bone formation will more easy. Then next time when we have good consolidation, we to do next step, we start elongation. This is depend of case. We haven't any protocol for all of patients. This is depend, because sometimes feeling inside of doctor more better than protocol. And
sir, in case of if the gap is much more, that means if the gap is more than 2 or 3 inch, that means 4 to 5 centimeter more, then do you do acute docking after refreshing of atrophic non-union case?
depend where. If till 2-3 centimeters possible in acute dock inside, but sometimes we to do dock inside very slowly. Then when we have contact with fragment, we again go to the operation theater, open, and good reduction of end of bone. Maybe sometimes we twice uh, acute reduction, this is in the first surgery. If slowly, step by step, this patient need second surgery for open reduction. Very, very sorry.
Finish?
So, that means, sir, I want to ask you one more question. That means, in that case, if there is more than 3 to 4 centimeter gap, then first time we have to open it and we have to transport the bone. And after transporting the bone, we have to again open it and we have to align it or we have to reduce it properly and then give compression. Is it the procedure that you follow?
Yeah, why? Because we have experience when result better when we do gradually remove gap and after a few weeks second surgery, because when we have acute reduction, sometimes this is possible, sometimes after acute reduction we remove gap, but blood circulation very bad coming because soft tissue like that, and this is situation not so good because coming big swelling. We have different patients, but if we have chance in the operation theater, put bone face to face, and in the operation theater make a good reduction. Yeah, possible, but without problem with soft tissue like that. For me, go second time to the operation theater, then have problem with soft tissue.
Okay, thank you, sir. Thank you very much. Professor Barisa, do you have any opinion regarding this atrophic non-union management by Ilizarov?
Atrophic non-union, if you see the bone ends are not good, you just cut millimeter by millimeter. Millimeter by millimeter, when you are seeing the paprika sign, that means blood is coming from the bone ends. Then after that, you should have to cut. Then what I do, if your bone is 2 or 3 centimeter or 4 centimeter, you can go for acute docking in the tibia. But femur, it is difficult. You can go for acute docking, and I put always a guide wire so that you can maintain the axis of the long bones in the tibia. And then you can go for, if you have infection, you can go for a corticotomy. Acute docking and go for lengthening. Lengthening, that means corticotomy. Corticotomy means theory of Ilizarov is to eliminate infection, vascularization of the infected center or osteomeric center is increased by the biological stimulation of corticotomy. You can do that. Even when there is infection, I always do a corticotomy and go for 10 millimeter, that is 1 centimeter lengthening. When you are going for corticotomy and lengthening, that is you are increasing circulation in the whole limb. You are getting new vascularization. That is the beauty of Ilizarov. When you are getting new vessels, that means you are creating a good healing process around the non-union side or infected side. And by Ilizarov theory, everything must be done gradually. You can do also gradually. You have a gap 2 to 3 centimeter. You can do the corticotomy and go for transportation. You can also do that. Both the ways are okay. This is the. Am I correct, Navikov?
And excellent explanation. And Dr. Barry, and why today I show so many pictures with the blood supply, with
Yes.
this funny net, we haven't result. And only imagine what will be with a small pipe when we acute broken all of
Yes.
blood circulation. And
Yes, correct.
this is must healing. No problem. We can open, we can put immediately, but what will be with blood supply? And all of our techniques very slowly. But
Yes,
this
everything
is
must be
any
done
treatment,
gradually.
any treatment, this is marathon. We cannot run too quick because
Yes.
we need grow blood vessels.
That's why the principle of Ilizarov methodology is very important.
Yeah,
New
you're
vessel,
absolutely right.
tissue
And
genesis,
when,
thermogenesis.
dear colleagues, when we start think not about bone, because in the our result, bone is last. Without skin, without muscles, without blood vessels, we
No,
cannot get result in the bone.
no, yeah.
Give
That's why
time
it's
and
called tissue
give
genesis.
our respect, all attention for soft tissue. Soft tissue will give us result with bone.
Bone, yes.
Thank you.
That is
Thank you.
very
Thank you
important
very
thing.
much, sir. Now, Professor Barrister told us about that. He always put a guide wire when there is a gap non-union there to maintain the alignment there. Sir,
Yeah.
do you practice that thing in Russia also?
Which kind of? Very sorry.
Hydroxyapatite.
Professor Barrister,
You are giving hydroxyapatite guide wire in the bones.
Yeah, this
Hydroxyapatite
is. You see, this is usually when we read this is articles. This is stimulator. Yeah.
stimulator,
Uh,
yes.
this is only my opinions. Any pregnancy needs stimulator.
Hmm.
I don't know why we need put inside again some metal, gold metal with hydroxyapatite. I haven't. Maybe I am not good surgeon. Maybe I cannot put. This is wire with hydroxyapatite. Maybe I cannot put. But I remember my father said, bone marrow. This is mother future bone. I think when I put inside any wire inside of bone marrow, this is this type of mother. Bone marrow for me, this is holy cow. Any young doctor put. I am not young doctor. I remember what say me my father. I want to take good baby without any stimulator.
No, because if you have a distance, diastase is very big. If you are going for bone transportation, to maintain the axis in the same line, you can put the guide wire inside, only K wire, so
Yeah,
that you can
yeah.
come
This
down.
is
That is a
absolutely. This is another way. This is another way. This is
this
God
is
why.
yeah, guide wire.
Absolutely. Just now we talk about regenerations.
Yes.
sir, what about the management of hypertrophic non-union? Do you have to open in case of hypertrophic non-union, or we can manage it completely in closed method?
Who is going to answer? He is
But,
answer.
What do you
yeah, Professor.
think, Dr. Barry? What your opinions?
Hypertrophic, I never open. What do you mean by hypertrophic? It means myriads of, thousands of callus cells around that non-union site. Only problem is that you are not giving any mechanical stability. There is an accordion method, just like you go for compression fast, 5 or 7 days or 10 days, then go for gradual distraction, compressing. You are creating billions of cells around the line of compression, and again, then you go for distraction. And this distraction will make you new bone formation. At the same time, if you have a shortening, you can gain that shortening also. So those who are looking at this, lot of other surgeons, they are opening the hypertrophic non-union, cleaning. Cleaning means you are destroying the cells, viable cells. Only one problem, you are not getting mechanical stability. By Ilizarov, you can give only mechanical stability, and you don't need to open up. Why you are disturbing all the cells? So
Only one,
Ilizarov,
Dr. Barry. Only one case. If we have patients and with many surgeries haven't result and not open with Ilizarov technique and cannot get result, yeah, we go and open. Why? Yeah, I am absolutely agree with you. First, we prepare material, then after compression, we use this material for bone callus. But sometimes we haven't, including baby.
Mm.
If after 2-3 times with close treatment we haven't result, yeah, we need open. And
Yeah.
sometimes must clean, sometimes must remove. This is depend. Very seldom, but we do this.
This
This
is
is
when
depend.
you have, yes, very big infection, then you can do that. I,
Yeah.
in general, hypertrophic, I don't open up. Either
And
crush and
usually
place
very
of
good examinations. Patient need very good examination, not only X-rays. Sometimes
yes,
CT, sometimes MRI,
yes,
and not opinions one doctor. And including, for example, I am experienced doctor. By I invite a young doctor. What you think? Because one brain good, but for eyes better. And for this case, we find good way with some concilium.
Thank you very much, sir. Thank you.
mm,
Professor Barrister, I want to ask one more question. Sir, you told that first you gave compression in case of
mm.
hypertrophic non-union for 4 to 5 days. Then you
No,
give
five,
destruction.
7, or maximum 10 days. This is called accordion method. You give
According.
compression, keep compression, compression osteogenesis. That means you are getting billions of cells around the line of compression, and then gradually you go for destruction. Destruction. It will create a
And
How many days will give the destruction, sir?
destruction. It
Uh,
will depend upon your case. If shortening or not, if callus is okay, your bone axis is okay, then you can stop destruction and keep it for 2 or 3 months. And as a result, it will fully consolidate and it will heal.
does it in a simultaneous process? We'll have to give the compression for 7 to 10 days. Then we'll give a destruction for three
This
to
is
four days.
not for all the time. This is not for all the time compression. That is accordion method. Whenever your big callus, stiff non-union, as for example, stiff non-union, and you have a big callus around the non-union site, you can go only destruction also. It depends on case to case. Not all the case the same. Even then, you can go for drilling in the non-union site to increase circulation, multiple KOFs. Even then, you can go for chipping. Chipping means potato chips. There is a one Japanese orthopedic surgeon with hypertrophic non-union. He is going for chipping, small chipping, and then compression and going for destruction.
and
Chipping also
again,
helps to,
what all of us to do? We invite blood
yes,
with compressions. From where coming these cells? From blood, from bone marrow.
mhm,
Then slowly again, we start to grow. We need
yes,
without blood vessels, without new blood vessels, we haven't chance to get excellent result. Very interesting topic, and any doctor has pseudoarthrosis, any doctor has defect. And again, without picture which you read with radiologist, you will not understand. I am happy man because my wife is a radiologist, and she called me, and she explained what's happened with my X-ray, and she catch me and stop me, please. Finished your lengthening because next step will come pseudoarthrosis or next step will defect because we are orthopedists must use experience from radiologist because I won't repeat again, this is 1, this is 11. When you
Yes.
will invite experience of radiologist, your results will multiply and you will fly.
thank you.
Thank you, sir. Thank you, sir. One last question from myself. You both of you told us that the vascularity is needed for healing purpose. So in case of hypertrophic non-union, can we do a corticotomy only to increase the vascularity of bones to help the healing process? We don't need any
Hypertrophic,
transportation.
no, hypertrophic means you have a good callus formation with vascularity. Only you are not giving mechanical stability. This mechanical stability, you can do it in two ways. By internally putting, that is not good. By externally, multi-axial, but from three-dimensional course with multiple K wires, you can compress. That is the stability of hypertrophic non-union by Ilizarov.
And only one way, if patient has shortening, and if patients haven't time, yeah, we can do. We can compress here, and we
And
can
corticotomy
do
and distraction.
corticotomy for lengthening, yeah.
Yeah.
And this is depend of health, this is depend from analysis, but sometimes, yeah, because all of these patients unique. We haven't two patients absolutely same. All of these patients unique.
Thank you. Thank you very much, sir. I think we can get lots of information by discussing with each other. And this is the beauty of sharing knowledge. Thank you, Professor Novikov sir and Professor Mufakarul Bari sir, for being with us and sharing your valuable knowledge and experience with us. Dear viewers, hope you are benefited by this session. And we will see you in the next Friday with another topic that will be definitely related with Ilizarov. And till then, I would like to say bye-bye to all of you. And I would like to thank Raj TV and definitely Renata Pharmaceuticals Limited for sponsoring these programs. And till then, bye-bye from Dr.
Thank you.
Tanvir sir.
Assalamu alaikum.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe